Dear friends and colleagues, ladies and gentlemen, welcome to the wrap-up view of the Thoraxcenter of the 2021 TCT meeting. My name is Nicolas from Mieghem from the Erasmus University Medical Center, and as always, it is my great pleasure to present this wrap-up together with my good friend and colleague Joost Daemen. Joost, there was quite a lot of talk about this TCT. I think there was
Absolutely.
a challenge with this hybrid construction. Unfortunately, we were not allowed to enter the country, but the content was quite interesting. So let's start with FAME3.
Yes, FAME3, so one of the anticipated studies that we looked out for at least. So the International Multi-Center Randomized Controlled Trial comparing contemporary PCI using FFR in all patients with 3-vessel disease as compared to contemporary CABG with a non-inferiority margin that was already quite broad. But interestingly, this trial did not meet its primary endpoint. So no non-inferiority of contemporary PCI as compared to CABG in patients with 3-vessel disease, with the exception of left main lesions. So a very interesting trial that showed higher MACE rates following PCI of around 10.9% as compared to MACE rates of 6.9% following CABG. And at the end, I think it's good to disentangle a little bit these MACE rates. So what is remarkable is that by using physiology, the MACE rates in this study, in which all patients were treated with the Resolute Onyx stents, were significantly lower than the Syntax 1 trial, and exactly comparable to the Syntax 2 trial, in which also contemporary stents were used. However, also imaging was used, which in this case was not the case. Only, I think, 12% of imaging in the FFR group. In the CABG arm, and that I found perhaps even more striking, is that the MACE rate in between Syntax and now FAME2, with a time span difference of around 10 years, was almost half. While, as far as I'm aware of, the technical advancements in CABG are not that particular that you would expect a reduction of MACE rates in a CABG arm by 50%. But still, interesting to provide a clear take-home message for me is a little bit difficult. There was a clear interaction between Syntax score. So at the end, what we learned is that in this overall population, CABG was superior. With a difference that was mainly driven by patients with very high Syntax scores, and that in a study in a population in which we know that the difference in harder endpoints is mainly driven in the diabetics. I'm not sure how this trial will change our practice in an era where also the use of imaging is increasing.
Well, it shouldn't, I think. Well, first of all, it's very difficult, and we should be very cautious comparing FAME3 with Syntax. Syntax was in the mid-2000s, right? And the baseline characteristics of those patients were totally different. We were still exploring the value of the Syntax score. So I would refrain from that comparison. That said, if you look at the patients with a low Syntax score, PCI actually did better, at least numerically, if you look at the Kaplan-Meier curves than surgery. But also that, to me, is not the major takeaway of that study. The study claims that it is contemporary PCI, but come on, 12% invasive imaging, that is substandard. We should not use invasive imaging in only 10% of our cases.
With 3-vessel disease.
With 3-vessel, it's not reproducible. And I was a little bit surprised by the attention and the heat it got, especially from the surgical community that were now saying, you know, look, this is the confirmation. Really, it is not the confirmation. And I think what we need to do is we need to establish and keep establishing this multidisciplinary approach, but also contemporary PCI is PCI that incorporates coronary physiology and invasive imaging. Otherwise, no point.
And I think we need to be realistic. 1,500 patients, 50 sites in 6 years, so that means 5-6 patients per site per year. So this is not a routine population.
No.
Okay, good. IFR Sweeter then, a bit more on physiology. Matthias Gottberg presented the 5-year results of the IFR Sweetheart trial. As you remember, non-inferiority study of IFR versus FFR. With event curves that were overlapping at 1 year, and guess what, at 5 years, as expected, continuously overlapping event curves for each of the individual endpoints. I guess not much more to say about that, except for the fact that this supports the use of non-hyperemic pressure ratios for clinical decision making.
And this definitely also fits within your research lines, of course, because you're doing a lot of research in this non-hyperemic coronary physiology, and I think this is the first trial that really proves that also in the long run you can safely stay away from hyperemia.
Absolutely. More interesting even, the FAVOR-3 trial. So FAVOR-3, to recall, the first large clinical outcome trial using angio-based FFR. In this case, 3,800 Chinese patients randomized to either a QFR-guided treatment strategy or angio-guided treatment strategy. In a trial that was designed for superiority, the QFR-guided treatment strategy in patients with intermediate lesions, defined as lesions with 50 to 90% degree stenosis. So that is a interesting detail in a study that actually met its primary endpoint, showed a absolute 3% difference in the primary endpoint in favor of QFR. So quite substantial. A difference that was driven by some degree of paraprocedural MIs in the angio-guided arm that exceeded the QFR-guided arm, along with a slight separation of the event curves up to 1 year. Few remarks about the trial. First, 2 positive comments. Were sort of blinded, so both the people assessing the endpoints as well as patients were blinded to the treatment allocation, as well as the fact that these patients were enrolled in only 13 months, which I think should be mentioned. Conversely, what I found striking is that 91% of the patients in the QFR arm got a PCI, which is quite interestingly. Mean QFR is extremely high. Yeah. Mean QFR value is 0.7. Whereas we know from FFR-guided trials that you defer 60+% of patients with intermediate lesions based on physiology, with mean FFRs of around 86, 87. So these were highly significant lesions that apparently all got treated.
So basically only 9% of the patients were deferred?
QFR altered treatment strategy in 23% of the vessels, but that could either mean treatment if you initially would have thought, I'm not going to treat it, or conversely. But on a patient level, it was 9%, and that resulted in an absolute 3% event difference. I find that quite substantial. But down the line, I think it's a intriguing study, an important piece of evidence that will absolutely will drive the future ongoing studies and potentially even help to drive adoption of this novel physiological index.
This is an Asian study, and I think it is really a call for more of these QFR kind of studies. And of course, FAST-3
just enrolled its first patient, so that will be the alternative to QFR with the Pi medical algorithm. So more to come on angio FFR. So far, to conclude on the physiology studies, you presented Certavi.
Yeah, so let's switch then to structural heart interventions. And Certavi was presented. I mean, I had the opportunity to present for the first time the 5-year data of Certavi. In brief, it's a trial that evaluated patients at intermediate operative risk. The mean STS was 4.5. The mean age was approximately 80 years old. Patients were randomized to either surgery with a bioprosthesis or TAVI with either a core valve in 84% of the cases or an Evolut R in 16% of the cases. So basically, we're talking about earlier generation transcatheter heart valves. At the end of the day, at 5 years, the primary composite endpoint of all-cause death and disabling stroke was exactly the same between the 2 treatment arms. And then if you look at endocarditis, valve thrombosis, the numbers were extremely low, less than 1% in the TAVI arm, so basically very reassuring. And then what also is important when we compare the both strategies is the re-intervention rate. And similar to previous trials, we see more re-interventions with TAVI. But then if you do the landmark analysis, and that was one of the highlights, at least in my opinion, of the data, is that between 2 and 5 years, you did not see a difference in re-intervention between the 2 treatment strategies. As a matter of fact, only 6 patients in the TAVI arm and 7 patients in the surgery arm required a re-intervention. So basically, the excess of re-interventions with TAVI predominantly was in the beginning, early after the procedure. And we are all aware from our early experience when patients went off the table with at least moderate paravalvular leaks, and then there was a discussion, do we need to do something or not?
Additional ballooning.
And then you decided, okay, let's stop here, but then the patient would come back. So basically now with new technology, with the sealing wraps and the repositioning of the valves, I think the results can only get better.
Yep.
So I was quite pleased with the results.
I can imagine. I think you should be congratulated for presenting this, and we look forward to the publication.
Yes, me too. So Partner 3 was the other trial that had a deep dive, and in Partner 3, David Cohen looked at the economic looked at it from an economic perspective, and it turns out that in brief, if you compare TAVI with a balloon expandable third generation device, the SAPIEN 3 versus surgery, we know at 2 years that basically TAVI was outperforming surgery in terms of clinical endpoints. Now also there seems to be an economic benefit. There is a small increase in quality adjusted life expectancy in favor of TAVI, but very small, 0.05 years. But then also the price at 2 years was less for TAVI than for surgery. And of course you have an increase in expenses early on because the transcatheter heart valve, exactly. But then because the patients stay longer in the hospital and they need to recover longer, that adds cost to the overall strategy. So at the end of the day, at 2 years, TAVI seems the more economically attractive approach, at least in a US healthcare perspective.
Yeah, interesting.
Yeah, well, we cannot do a preview or a wrap-up without talking about renal denervation.
Yes.
So give it us.
Also this TCT, some update on the renal denervation trial. In this case, the 6 months results of the Radiance Trio trial, as presented by one of the two co-PIs, AJ Courtney, who demonstrated or showed the results of Trio up to 6 months. So we know, just as a refresher, at 2 months, ultrasound-based RDN significantly decreased blood pressure on top of a fixed triple pill combination for antihypertension as compared to a sham treatment with around 4.5 millimeters of mercury. Significant difference at 2 months, which was the primary endpoint of the trial. Now at 6 months, meaning an additional 4-month interval in which physicians were allowed to apply, or actually mandated to allow, a standardized stepwise antihypertensive treatment escalation protocol, we found that blood pressure differences were no longer significant between both cohorts. However, in the sham arm, the number of cases that were actually put on spironolactone was substantially higher as compared to the RDN group. So a somewhat higher drug burden in the sham group as compared to the RDN group. Moreover, home blood pressure measurements were still in favor of the RDN group, and thereby significantly lower as compared to the sham cohort. So in brief, interesting data that attests to the fact that this therapy has the potential to be an interesting alternative to pharmacological treatment in patients with therapy-resistant hypertension. Not something that will probably replace the need for antihypertensive drugs, but should definitely be seen as an adjunct technology that could help us to drive normal tension in patients with hypertension.
Yeah, we discussed this beforehand, and I agree with that statement. What I would think is, okay, we are now at 6 months, but of course, how durable will it be? 6 months is not a long time, so how will it be at 2 years, at 5 years? You know, if you look at durability of valves, for instance, you really need a longer follow-up. And I think we will hear much more about Radiance HTN in the future.
Absolutely, absolutely.
Okay, let's go back to some structural work. There was this choice closure trial that was presented by Mohamed Abdel Wahab. This is an interesting study, basically a follow-up to the MESH trial that we conducted together with our friends from Toulouse. This trial was bigger, was more than twice as large in terms of patient enrollments. And initially we thought it was just a single center. It turned out to be a 3-center experience. But 258 patients were randomized in each treatment arm to either MANTA closure or Perclose ProGlide closure. Because they had a larger sample size, the differences became more clear between the two treatment arms, but basically it was not so different from what we demonstrated in MESH. So there were more, the primary endpoint were any access site related complication, and that occurred more often with the MANTA in 19% of the cases versus 12% with the suture-based closure. These numbers were definitely higher, were more than double of the numbers that we did. And then if you take a more deeper dive into the data, then it also turns out that only 12% of the patients had ultrasound guidance in terms of access. And I don't know what to do, but I think we need to inform our German colleagues the importance of ultrasound guided access. Come on, if you do not do that, you're a little bit in the, this is not, then you are doing TAVI in the early 2000s. There is such a big advantage in doing ultrasound guided access, and that was a little bit of a bummer, I think. On the other hand, also only the 18 French MANTA was used. And so from the data, it is not clear how many patients were treated with an Evolut system that is 14 French equivalent. Because if you would only use an 18 French MANTA, that means that you will up-titrate, you will make the hole larger, so you will expose the patient to more risk, because of course a larger hole will create more damage than a smaller hole. So why would you only use an 18 French MANTA? That said, I think the key message here is that you will have more control of your access because of the safety wire with suture-based closure. But in principle, if you do proper patient selection, MANTA is definitely a good closure device. So when you see these data, you also do quite a lot of these procedures yourself. What kind of a percentage do you use MANTA and suture-based closure in your practice?
I would say we're around 50-50. But what I found interesting in this trial is that when you look into the event rates, I mean, you see a overall access site complication rate of 9% higher, or 8 or 9% higher in choice closure as compared to mesh, driven by a difference in both major access site bleedings, which was twice as high as in mesh, but mainly also minor. So it's not just the minor oozing that was different, also the major bleedings, despite the fact that all these patients got protamine, and even that is something we don't do, specifically not for our suture-based closures.
But you know, at first glance you would say, oh, MANTA is definitely inferior to suture-based closure. I think we should take that with a grain of salt, because also the main difference was driven by BARC2 bleedings. So clinically, so not the major bleedings or the life-threatening bleedings, but only BARC2 bleedings and pseudoaneurysms. So those are quite soft endpoints that were driving the primary endpoint. But okay, I think we gave that message. Then Swiss Apéro. That was this trial from our friends in Switzerland, where they looked at the difference between amulet or a Watchman device in terms of peri-device leakage. And they were aiming for a superiority with amulet, and it turned out to be superior. So there were more peri-device leaks with the Watchman. Also of interest and different from the amulet IDE trial, in the majority of Watchman cases, the last generation Watchman Flex was used. But then if they dive into their data, it turns out that all the device leaks were with the former generation device. So basically, it becomes very difficult to draw a final conclusion here. But what was also noticeable and similar to the amulet IDE trial, there were more procedure complications with amulet. So I don't think that Swiss Apéro or amulet IDE can help us with device selection at this point in time. I do think that we are learning as a community how to use these devices, and probably we'll end up with a patient-specific device selection at one point.
Absolutely. Intrepid?
Yeah, so the Intrepid, it was a little bit unclear what they were going to present at TCT this year, but they were presenting the early feasibility study of this transeptal Intrepid device. That was highly interesting, I think. It was, but a very small study. Only 15 patients were included, and basically the device worked. So in terms of mitral regurgitation, that was more or less gone after the valve implants. But we were talking about a 35 French device. This is like a monster to be used in a transeptal procedure. And it turned out that 70% of the cases, the transeptal hole was closed with a closure device.
About to ask.
And I don't think that is very attractive down the stretch. And then there were also access site complications. So 6 out of the 15 patients had a major access complication. So I think this is the way forward. I think we need transcatheter mitral valve devices. but they need to be below less than 30 frames.
Yeah, absolutely, maybe even less than 20.
Exactly. Then the other takeaway was a very fast procedure, only 45 minutes.
That is interesting.
So that is compelling. So I do believe that this is the technology in the near future.
Yeah.
So let's finally mention also the erosion 3, because now we discussed coronary physiology, but this is a study more on imaging again.
Yeah, so this is the final study we want to briefly address. This is erosion 3, a randomized controlled trial about OCT-guided stenting in patients with STEMI. As mentioned in our preview, not focused on clinical outcome, but focused on how OCT in patients presenting with ACS, and please be of note, so patients with a TIMI flow that had to be above 2 plus a lesion with a diameter stenosis less than 70%, to see if OCT could withhold the operator from stenting in cases of SCAD or small erosions, or cases with calcified nodules in which the luminal area was still, let's say, around 4. And that appeared to be the case. If you use OCT, you implant stents in 15% of the cases, lower as when you would not use OCT. So in absolute figures, a difference of 44 versus 59% of cases that underwent stenting in a STEMI setting, driven by the use of OCT. To me of interest, because of the fact that this drives the concept of being perhaps sometimes a bit more reluctant to put stents in complex anatomies presenting with STEMI, in which the luminal area is still sufficient from a physiological standpoint, in case there is proper flow. Interesting, no differences in the clinical endpoints in this study, which was obviously not powered for clinical endpoints, but food for thought, and I think something to look further for in the future.
Yeah, and but we also have to be aware that this trial focused on a very specific subset of patients, right? This is STEMI patients with TIMI3 flow and lesions less than 70% in diameter. That's not the bulk of our cases. That is the minority of our cases. But I would agree with you. This is a trial that is another call to be maybe more aggressive in terms of invasive imaging and not overly aggressive in terms of stenting. With that, I like to thank you, of course, for your expert intervention here. I would like also to thank the audience for sticking with us. Thank you very much, and we do hope to see you in person soon.
Thank you, and bye-bye.
Bye.